Hi, and welcome back to Ready, Set, GYO, your on-the-go guide to learning gynecologic oncology. I'm Sydney.
And I'm Maya. This is a podcast for fellows by fellows. We are here to help you explore the diagnosis and treatment of gynecologic cancers, master the standards of care, and stay on top of new practice-changing publications.
Let's get ready to GYO! Welcome back. In our last episode, we discussed the epidemiology, staging, and treatment recommendations for early-stage cervical cancer. Today, we're going to learn how to venture into the world of locally advanced cervical cancer. Maya, what are our learning objectives?
Our learning objectives are to define locally advanced, metastatic, and recurrent cervical cancer, to discuss standard treatment options for locally advanced cervical cancer, to explain the choice of chemotherapy agent to use with concomitant radiation, to discuss the use of immunotherapy in the treatment of locally advanced cervical cancer, to review the evidence evaluating the use of neoadjuvant chemotherapy in locally advanced cervical cancer, and to discuss the use of adjuvant chemotherapy in locally advanced cervical cancer.
Awesome. Locally advanced cervical cancer describes stage 1B3 to 4A according to the FIGO 2018 staging system. This is with the exception of stage 2A1, which is considered early stage disease and was discussed in our last episode. Stage 1B3 is confined to the cervix with a clinically visible tumor greater than 4 centimeters in the greatest dimension, also termed, quote, bulky disease. Stage 2 tumors invade beyond the uterus, but not to the pelvic sidewall or lower one-third of the vagina. Stage 3 disease extends to the pelvic sidewall and or the lower one-third of the vagina and or causes a hydronephrosis or non-functioning kidney and or involves the pelvic or periaortic lymph nodes. Stage 4A disease involves the mucosa of the bladder or rectum and or extends beyond the true pelvis. Stage 4B, metastatic disease, will be discussed in our upcoming podcast episode.
Patients with locally advanced cervical cancer have a worse prognosis than those with early stage disease, and the 5-year survival rate declines drastically with increases in stage. The 5-year survival rate for stage 1B disease is about 80% compared to 16% if this disease is stage 4A. Disease control after therapy and overall survival is worse with nodal involvement. In general, for locally advanced disease, the risk of recurrence is 30 to 40% after primary treatment. Prior to treatment, a PET-CT should be obtained to evaluate the extent of disease and to help tailor radiation planning. One can consider a biopsy of PET-avid nodes to confirm metastasis, or can use imaging alone if nodal enlargement and PET avidity are convincing. If there's evidence of renal impairment, this should be further worked up to determine whether it's arising from cervical cancer or another medical cause. If there is urinary tract obstruction, this should be addressed and corrected prior to initiation of chemoradiation. Those who present with kidney failure as a result of their disease-related hydronephrosis may have normalization of their kidney function and improved oncologic outcomes after the obstruction is resolved. This is supported by a retrospective study by Rose et al. In 2010, which compiled outcomes of patients with stage 3B cervical cancer in 4 GOG studies. They found that among patients with ureteral obstruction and hydronephrosis, relief of the obstruction was associated with improved overall survival. Okay, so my patient comes in, is diagnosed with a locally advanced cervical cancer, and is ready for treatment. What's the next step?
The next step would be referral to a radiation oncologist for chemoradiation with or without the addition of immunotherapy. The preferred treatment for locally advanced cervical cancer in the NCCN guidelines is chemoradiation, which includes EBRT with concurrent platinum-based chemotherapy followed by brachytherapy, and pembrolizumab depending on stage, based on the results of Keynote A18, which we'll discuss later. Chemoradiation has been the standard of care for locally advanced cervical cancer since the publication of GOG 123 in 1999. During this episode, we will use the term brachytherapy inclusively to describe both vaginal and cervical brachytherapy. Let's talk about the path to standard chemoradiation, our backbone of treatment. GOG 123 was a randomized control trial of 369 patients with bulky stage 1B cervical cancer with negative lymph nodes who were randomized to radiation alone, meaning EBRT plus brachy, versus chemoradiation, EBRT with concurrent cisplatin plus brachy, followed by hysterectomy for both groups. Progression-free survival and overall survival both favored chemoradiation versus radiation alone. Long-term follow-up, published in 2007, showed a 6-year PFS of 71% versus 60% and a 6-year overall survival of 78% versus 64%, both favoring chemo-RT. Overall, late adverse events were uncommon and not different between the groups. GOG 71 asked the question of whether adding hysterectomy to radiation for bulky cervical cancer, being stage 1B2, would improve outcomes. In GOG 71, neither PFS or OS were improved by the addition of hysterectomy to radiation. Combining the results of these two studies, which showed that adding hysterectomy to radiation doesn't improve outcomes, and that chemoradiation is better than radiation alone, made chemoradiation the standard of care. There have been additional studies that confirm these findings, which we'll discuss later in this episode. Radiation therapy is a topic we all may be a little less familiar with. Maya, what exactly is EBRT and brachytherapy?
Great question. EBRT stands for external beam radiation therapy. It's usually delivered in fractions for a total dose measured in gray, which is abbreviated GY. The total dose is dependent upon the burden of disease. Typically, it's 40 to 50 gray for microscopic or low volume disease and 70 plus gray for gross disease. A boost to nodal disease may also be added. Brachytherapy provides close contact, local radiation doses to the cervix and vagina, allowing for higher delivery to the tumor while limiting exposure to the surrounding organs as much as possible. It usually starts in the weeks after EBRT once the tumor size has shrunk. The dosing and mode of delivery is complicated. The use of image-guided brachytherapy is emerging as a strategy to increase the dose to the relevant tissue while sparing toxicity to normal tissue. More to come about how these techniques are administered and work in the upcoming Radiation Fundamentals episode.
So how did we get to the recommendation of combining EBRT with brachytherapy?
Another great question. In the early 2000s, the rate of vaginal brachytherapy decreased, while rates of intensity modulated radiotherapy, IMRT, or stereotactic body radiation therapy, SBRT, increased. These advanced radiation technologies ended up having inferior survival when compared to brachytherapy. Multiple retrospective population-based studies have since shown improved disease-specific and overall survival with the addition of brachytherapy to EBRT. This was confirmed by an updated study published by Han et al. In 2024 in the International Journal of Radiation Oncology, which looked at trends and practices in use of brachytherapy in cervical cancer in the US from 2000 to 2020. In a cumulative sample of 8,500 patients with FIGO 2009 stage 1B2, which correlates to FIGO 2018 stage 1B3 disease, to stage 4A disease, they noted a nadir of use in brachytherapy in 2003 and 2004, which then slowly increased to 75% in 2020. This analysis demonstrated that the use of brachytherapy was associated with an improved 4-year overall survival of 64 versus 51%, as well as improved cancer-specific mortality and all-cause mortality with a hazard ratio of 0.72.
Time to completion of treatment is really important and is associated with improved survival outcomes. Treatment completion within 8 weeks has been suggested. There aren't great prospective trials looking at therapy completion with chemo-RT, but this can be extrapolated from studies on RT. Several retrospective studies have shown improved rates of pelvic control, and in some studies, improved overall survival with expeditious treatment. Okay, got it. So when we say chemo-RT, what we're referring to is EBRT with concurrent platinum-containing chemotherapy followed by brachytherapy. Is there a role for any additional radiation?
Sometimes. Involvement of the para-aortic lymph nodes is an independent prognostic factor. If involved, the 5-year survival is about 40%. There's limited evidence of survival benefit for using extended field radiation therapy, or EFRT, in combination with chemotherapy to cover the para-aortic nodes, but it is often done in practice. Small studies have suggested benefit to this approach, but at the cost of increased toxicity. RTOG 7920, published in 1990, randomized patients with bulky cervical cancer without evidence of para-aortic nodal disease and no plan for curative surgery to either pelvic radiation alone or pelvic and para-aortic radiation. The 5-year overall survival improved from 55 to 65% with the addition of para-aortic radiation. In patients with only pelvic RT, there were higher rates of distal first recurrent or failure. On long-term follow-up, published in 1995, the 10-year overall survival was 55% versus 44% in favor of pelvic plus para-aortic radiation. In the setting of prior abdominal surgery, the incidence of grade 4 and 5 toxicities was much higher, 11% versus 2%, with the addition of radiation to the para-aortic nodes. It's important to keep in mind that this trial evaluated radiation alone and not chemoradiation. Chemotherapy boosts the efficacy of radiation, but also may aid in distant failure control and decrease the rate of distant recurrence. It's hard to extrapolate whether this benefit of para-aortic radiation persists in the setting of chemo-RT. RTOG 9001, published in the New England Journal of Medicine in 1999 with long-term follow-up in 2004, attempted to address this question. The study randomized over 400 patients with stage 2B to 4A disease to extended field RT versus pelvic RT with cisplatin and FU. That was the chemo RT arm. In this study, both PFS and OS favored the chemo RT arm with a 5-year overall survival of 73% versus 58%. The chemo RT decreased both local and distant recurrences. The overall survival benefit was more pronounced in patients with earlier stage disease, and rate of serious late complications were similar between the groups. Let's take some time to discuss the landmark trials on chemo-RT in more detail. What has been discovered in the past that informs our care today?
Let's do it. In 2010, Alberts et al. Published a meta-analysis of all randomized controlled trials evaluating chemo-RT versus RT alone. They found a 6% improvement in 5-year overall survival with a hazard ratio of 0.81. There was a larger survival benefit in the two trials in which chemotherapy followed initial chemo-RT versus RT alone, i.e., with adjuvant chemotherapy, with an overall survival benefit of 19% and hazard ratio of 0.46. Later in this episode, we'll discuss trials that specifically evaluated the use of adjuvant chemotherapy. Benefit was seen with use of both platinum and non-platinum chemotherapy. There have been more recent randomized controlled trials evaluating the benefit of chemoradiation. In 2014, Zuliani et al. Published an RCT comparing cis-XRT versus radiation alone in FIGO stage 3B squamous cervical cancer. The trial design was based on results of previous trials that had suggested that the benefit of chemoradiation versus radiation alone may decrease with later stage disease, as we mentioned before. However, in this later stage group, they still found a disease-free survival benefit towards chemoradiation with a hazard ratio of 0.52. Long-term outcomes of the Zuliani study were published by Ficini et al. In 2020. While in the original publication, overall survival had not been significantly different between the radiation and chemoradiation arms, with extended follow-up data, they found that disease-free survival and overall survival improved with chemoradiation, with a hazard ratio for overall survival in the radiation alone group of 1.88. In a very similar study published in 2018, Shrivastava et al. Published a RCT comparing cisplatin RT versus RT in FIGO stage 3B squamous cell carcinoma of the cervix. 850 patients were included. 5-year disease-free survival was 52 versus 44%, and 5-year overall survival was 54 versus 46%, both statistically significant and both favoring chemo-RT. There were higher rates of acute hematologic events with the chemo-RT arm. So, based on these studies, we have definitive evidence that chemo-RT, again meaning EBRT plus concurrent platinum-containing chemotherapy followed by brachytherapy, is better than RT alone, EBRT followed by brachytherapy. We know that we've been a little vague about the chemotherapy portion of these regimens. Maya, what do we use and why do we use it?
According to the NCCN, the preferred regimens are cisplatin or weekly carboplatin at AUC2 if the patient is cisplatin intolerant. There's limited retrospective data that suggests similar outcomes with the use of carboplatin versus cisplatin when combined with radiation. Some possible contraindications to cisplatin include chronic renal failure or severe baseline neuropathy. If the patient originally had kidney dysfunction due to tumor related urinary obstruction and this resolves, that's not a contraindication to cisplatin use. If cisplatin or carboplatin are not available, the NCCN lists other potential agents which can be used if these preferred options are unavailable. Historically, both hydroxyurea and fluorouracil have been used in the treatment of cervical cancer, with 5-FU often combined with cisplatin. GOG 85, published in 1999, determined that hydroxyurea alone was not as effective as cisplatin and 5-FU. GOG 120, published in 1999, found that any regimen which included cisplatin was better than hydroxyurea alone, and the cisplatin alone had similar outcomes to cisplatin with 5-FU and hydroxyurea. Finally, Kim et al. In 2007 determined that cisplatin alone versus in combination with fluorouracil had equal survival outcomes with a more favorable side effect profile, leading to improved completion rates. So it seems like we've left fluorouracil and hydroxyurea behind, and that cisplatin alone, with the caveat of carboplatin or other options in the setting of intolerance or access issues, are our chemotherapy of choice for chemo-RT. What about dosing and frequency?
Most published trials have administered cisplatin weekly. Rue et al. Sought to answer this question in 2011. They randomized patients with stage 2B to 4A cervical cancer to cisplatin 40 milligrams per meter squared weekly times 6 cycles versus cisplatin 75 milligrams per meter squared every 3 weeks times 3 cycles. They found that compliance with treatment in the tri-weekly regimen was 92.5% versus 86% in the weekly group, and that grade 3 to 4 neutropenia was also lower at 23% compared to 39% in the weekly dosing. In this study, 5-year overall survival was 88.7 months versus 66.5 months, favoring the tri-weekly regimen. Tri-weekly cisplatin was shown to be more feasible and more effective. Now, there were some critiques of this study. First, a substantial number of patients had positive periaortic lymph nodes in both arms, and the radiation field was not specified. 2, they reported periaortic recurrences, but the trial did not state if the nodes were originally treated. And 3, there were unclear definitions of cause-specific survival. For instance, they did not specify which salvage therapy was used for recurrence. This is important because although the recurrence rates weren't different between the two arms, the survival was. Luckily, though, we have another study, the TACO trial, which is ongoing and evaluating weekly versus tri-weekly cisplatin with concurrent radiation. We look forward to these results and hope that this will give clarity about the optimal timing and dosing of cisplatin.
Okay, I got it. It now makes sense that chemo-RT carries a Category 1 recommendation from the NCCN. What about our patients who can't tolerate chemo-RT or have a contraindication? And also, what about patients who don't respond to chemo-RT?
So there's a Category 2A recommendation for radical hysterectomy with pelvic lymphadenectomy with or without periaortic lymphadenectomy for patients with tumors greater than 4 centimeters that are otherwise resectable. There's also a Category 3 recommendation for chemoradiation followed by, quote, selective completion hysterectomy. This should only be considered if there's a poor response to initial treatment with evidence of residual disease in patients in whom brachytherapy is not feasible. I'll give some examples of patients that may be poor candidates for primary chemo-RT. Patients with acute or chronic pelvic inflammatory disease, a coexisting pelvic mass that suggests possible dual malignancy, anatomic changes or Müllerian anomalies that would make optimizing radiation difficult, or in patients in whom compliance with RT would be difficult. In patients who are poor candidates for chemo-RT, RT alone can be considered, but remember that this is inferior treatment. Similarly, patients with stage 1b3 disease could potentially undergo a modified radical hysterectomy, but this is not the standard of care. I think that rounds out our discussion of chemo-RT for locally advanced cervical cancer. But I do know we live in a new age of cancer care. Do we have any other additions to the cytotoxic chemotherapies given with radiation?
We do. Since the publication of Keynote A18, the NCCN guidelines have been updated to include pembrolizumab for patients with higher stage locally advanced cervical cancer. HPV-driven cancers, like cervical cancer, have an immunosuppressed tumor environment, with high rates of PD-L1 positivity in HPV-dependent disease. Tumors with squamous histology tend to have higher PD-L1 positivity in the range of 80 to 90% than do adenocarcinomas. We'll talk more about PD-L1 as a target in our upcoming immunotherapy episode. Keynote A18 was a double-blinded, phase 3 randomized controlled trial which compared the use of pembrolizumab with chemo-RT versus chemo-RT alone. Final overall survival results were published in October 2024 by LaRusso et al. In The Lancet. The trial enrolled 1,060 patients with high-risk, locally advanced disease, defined as FIGO 2014 stage 1B2 to 2B node positive and stage 3 to 4A regardless of nodal status, which correlates now to the FIGO 2018 stage 3 to 4 disease. Squamous cell, adenocarcinoma, and adenosquamous histologies were included. They were stratified by planned type of EBRT, by stage, and by planned total radiotherapy with a 70 gray cutoff. All patients received chemo-RT plus minus 5 cycles of pembrolizumab, 200 milligrams every 3 weeks, followed by pembrolizumab maintenance, 400 milligrams every 6 weeks for a total of 15 cycles. At the first interim analysis, PFS at 24 months was 68 versus 57% favoring pembrolizumab, with a median PFS not reached in either group at the time of result reporting. With publication of the second interim results, an overall survival benefit for pembrolizumab was also demonstrated, with a median overall survival at 36 months of 82.6% in the pembrolizumab arm versus 74.8% in the placebo arm, with a hazard ratio of 0.67 and a p-value of 0.004. In subgroup analysis by stage, this overall survival benefit seemed to be limited to patients with FIGO 2014 stage 3 to 4A disease and not the earlier stage node positive patients. And younger patients, less than 65 years old, benefited more than older patients. Patients in the Pembro chemo-RT group had a higher rate of hypo and hyperthyroidism, leukopenia, hypokalemia, and increased AST levels. Rates of greater than grade 3 adverse events were 78% in the Pembro group versus 70% in the chemo-RT group. There were no grade 3 adverse events that differed more than 5% between the groups, and treatment completion rates were identical between the two groups. 95% of tumors were positive for PD-L1, with a PD-L1 combined positivity score, or CPS, of more than or equal to 1. As a reminder, the CPS is calculated by determining the percentage of the total number of PD-L1 positive cells, including tumor, lymphocytes, and macrophages, compared to the total number of tumor cells. There was a hazard ratio for disease progression or death in the PD-L1 positive group of 0.66 versus 1.06 in the PD-L1 negative group. Interpretation of the PD-L1 negative results needs to be considered carefully given the small sample size. Based on the overall survival results from Keynote A18, the NCCN recommends the addition of pembrolizumab to chemo-RT as Category 1 for FIGO 2014 stages 3A, 3B, and 4A. However, for patients staged as FIGO 2018 stage 3C, purely on the basis of nodal metastases, meaning without the local tumor characteristics that define FIGO 2014 stage 3, such as lower vaginal involvement, pelvic sidewall extension, or hydronephrosis, the recommendation is Category 2B. based on the less robust response seen in these subgroups. Pembrolizumab carries FDA approval in combination with chemo-RT for patients with FIGO 2014 stage 3 to 4A cervical cancer, regardless of PD-L1 CPS. Sydney, do we have other trials in locally advanced cervical cancer looking at the use of immunotherapy?
We certainly do. The CALA trial, published in 2023, investigated a very similar compound, durvalumab, in combination with chemo-RT versus placebo. As a reminder, which we will further explore in our upcoming immunotherapies episode, pembrolizumab is an anti-PD-1 compound and durvalumab is an anti-PD-L1 compound. The CALA trial was a double-blinded phase 3 RCT with a very similar patient population to that of the Keynote A18 trial. Patients were stratified by disease stage, including both FIGO 2009 stage and lymph node status. 770 patients were included, and they underwent chemo-RT plus minus durvalumab with durvalumab maintenance up to 24 cycles. 96% of patients had a PD-L1 tumor area positivity TAP score of 1% or greater. TAP is a visual estimation of the area of tumor cells and immune cells that are positive for PD-L1 relative to the total tumor area. Generally, TAP of about 5% correlates with a CPS of 1. 83% of patients in the durvalumab group and 82% in the placebo group had a PD-L1 TAP score of 5% or greater. 12-month PFS was not different between the two groups, and median PFS was not reached in either group. Grade 3 or greater adverse events occurred in 28% of patients in the durvalumab group and 23% of patients in the placebo group. It's important to note that there were 5 treatment-related deaths in the durvalumab group versus 1 in the placebo group. In exploratory analysis, the only group who had benefit from the addition of durvalumab were those with a TAP score of greater than 20%, which was about 50% of patients. This study suggests that durvalumab in addition to chemo-RT may warrant further exploration for use in patients whose tumors have high PD-L1 expression.
A phase 3 trial, NRG GY006, was published in Gynonc in 2025, investigating triapine, a small molecule drug acting on ribonucleotide reductase, in addition to the use of chemo-RT. This was a negative trial. Additional abstracts without mature data include the NICOL trial evaluating nivolumab in addition to chemo-RT and GOTIC 018, a phase 1 trial of nivolumab and concurrent chemo-RT followed by nivolumab maintenance. All right, so we've discussed neoadjuvant chemotherapy in our past episodes for uterine and ovarian cancer. Does it have a role in cervical cancer?
Over the last few decades, there have been several trials evaluating whether neoadjuvant chemotherapy followed by surgery was equivalent or superior to primary chemoradiation with no surgery. The majority of these studies have been conducted in patients with stage 1B2 to 2B disease and not later stage locally advanced cervical cancer. None of these trials have shown a survival benefit to neoadjuvant chemotherapy followed by surgery versus primary chemoradiation as definitive treatment. And in some studies, neoadjuvant chemotherapy plus surgery has been associated with a worse disease-free survival. In an editorial in the New England Journal of Medicine in 1999, they highlighted that 8 out of 9 published trials of neoadjuvant chemotherapy in cervical cancer had revealed no significant benefit to its use. Maya, can you tell us about some of the key trials published since 2000 looking at neoadjuvant chemotherapy in cervical cancer?
Absolutely. GOG 141, published in 2007, compared vincristine and cisplatin neoadjuvant chemotherapy followed by surgery versus surgery alone in patients with FIGO 1995 stage 1B tumors, i.e., tumors greater than or equal to 4 centimeters. The study was closed prematurely due to slow accrual, but among enrolled patients, the recurrence and death rates were not different between the two groups. In 2018, Gupta et al. Published a phase 3 randomized controlled trial comparing neoadjuvant chemo with carbotaxol for 3 cycles, followed by radical hysterectomy versus standard chemo-RT, so cisplatin with EBRT and VBT. They had 633 patients with FIGO 1995 stage 1B2 to 2B disease that were included. The 5-year disease-free survival was 76.7% versus 69.3%, favoring the chemo RT arm, but the difference was not statistically significant. There were no differences in the 5-year overall survival rates. There were higher rates of vaginal toxicity of 26 versus 12%, and rectal and bladder toxicity of 3.5 versus 2% in the chemo RT group.
These results were recapitulated in 2023 with the EORTC 55994 trial. This was a phase 3 RCT of 626 patients with FIGO stage 1B2 to 2B disease comparing neoadjuvant chemotherapy, being a platinum-based agent for 3 cycles, followed by radical hysterectomy, versus standard chemo RT. 71% in the neoadjuvant chemotherapy plus surgery arm completed therapy versus 82% in the chemo RT arm. 5-year overall survival was not different between the groups. Short-term adverse events were more common in the neoadjuvant chemotherapy plus surgery group, 41 versus 23%, and long-term adverse events were more common with chemo RT, 21 versus 15%. Adjuvant radiation was recommended in the case of surgically proven lymph node metastases, parametrial invasion, or positive surgical margins. Notably, 48% of the patients in the neoadjuvant chemotherapy plus surgery group ultimately received additional radiation. It's important to note that in some parts of the world, access to chemoradiation is very limited. In these locations, if time to access chemoradiation is going to be significantly delayed or even impossible to reach, neoadjuvant chemotherapy followed by surgery may be more practical and end up providing superior oncologic outcomes. In the US and other places where access to chemoradiation is readily available, it seems that no studies have shown clinical benefit to neoadjuvant chemotherapy plus surgery compared to chemo RT, and that many patients who get neoadjuvant chemotherapy and surgery may end up requiring radiation as a part of their treatment. As such, this strategy is not currently the standard of care. Maya, how does neoadjuvant chemotherapy differ from the term induction chemotherapy?
Great question. Induction chemotherapy refers to chemotherapy prior to primary chemoradiation. The important difference in these next 2 trials is that we aren't changing the definitive treatment regimen of chemoradiation, we're just adding extra chemotherapy prior to that treatment. In 2019, Cabral et al. Published a phase 2 study of 107 patients evaluating the utility of neoadjuvant chemotherapy with cisplatin and gemcitabine prior to chemo RT versus chemo RT alone. Both the PFS and OS were significantly improved in the chemo RT alone arm, with a 3-year overall survival of 87% versus 61%. The authors concluded that the treatment agent choice and dosing of cisplatin 50 milligrams per meter squared and gemcitabine 1,000 milligrams per meter squared may be affecting the potential benefit of induction chemotherapy, and they pointed to the ongoing Interlace trial as another study which may provide answers. The Interlace trial published initial results in abstract form in 2023, and the final manuscript was just published on October 15th of 2024. 500 patients with FIGO 2008 stage 1B1 node positive, 1B2, 2, 3B, and 4A disease were enrolled. It excluded patients with stage 3A disease. The trial compared chemo RT alone with weekly cisplatin versus induction chemotherapy with carboplatin AUC2 and Taxol 80 milligrams per meter squared, followed by chemo RT. At the time of the publication of the manuscript, there was a median follow-up of 67 months. The 5-year PFS was 72% in the induction chemo followed by chemo RT arm and 64% in the chemo RT alone group, with a hazard ratio of 0.65. The 5-year overall survival was also improved in the induction chemo RT group, with 80% versus 72% and a hazard ratio of 0.6. 92% of patients in the induction chemotherapy group completed 5 out of 6 cycles of induction chemo. During the administration of chemoradiation, 68% of patients in the induction chemo arm and 79% of patients in the chemo RT alone arm completed all 5 cycles of cisplatin. Rates of delivery of radiation were high and were similar between arms, and overall radiation treatment time was the same in both groups, with 96% of patients in both groups completing radiation in less than 8 weeks. At time of abstract publication, aspects of the trial design and recruitment process led some to express caution in a widespread change of practice based on this trial. In the intention to treat population, only 14% of patients had FIGO 2018 stage 3 to 4 disease, and the trial accrued over 10 years. With the addition of novel immunotherapy agents, it'll be interesting to see how application of these different therapies get incorporated into the standard of care. In the NCCN guidelines, the interlace induction chemotherapy regimen is included in the Other Recommended Therapies section.
Thanks, Maya. There have also been some trials looking at adding adjuvant chemotherapy after completion of primary chemoradiation. In 2011, Duenas-Gonzalez et al. Published a phase 3 RCT comparing standard chemo-RT with cisplatin versus chemo-RT with cisplatin and gemcitabine, followed by cisplatin plus gemcitabine adjuvant therapy. In the combination group, there was an improved PFS and OS, both with hazard ratios of 0.68. However, the toxicities were doubled in the combination group, with 86% of patients in the combo arm having a grade 3 to 4 toxicity. It's also difficult to interpret from this trial whether the improved oncologic outcomes were due to the addition of gemcitabine in the concurrent radiation therapy or to the adjuvant therapy.
This was followed by the Outback trial, published in 2023. This was a phase 3 RCT comparing chemo-RT followed by 4 cycles of adjuvant carbotaxol versus chemo-RT alone. 919 patients with locally advanced cervical cancer, so FIGO 2008, stage 1B1 with nodal involvement 1B2, 2, 3B, or 4A, were included. There were no differences in 5-year PFS or OS. Again, toxicity was much higher in the combination group, with higher than grade 3 adverse events observed in 81% versus 62% in the chemo-RT alone group. Based on the results of these two trials, adjuvant chemotherapy following chemo-RT is not typically given.
Finally, we wanted to touch on an emerging technology. Use of circulating tumor DNA is emerging as a way to detect patients at high risk of recurrence. A study by Han et al. Published in 2023 evaluated the impact of detectable HPV circulating tumor DNA, ctDNA, at the conclusion of chemo-RT treatment for patients with locally advanced cervical cancer. Patients with detectable HPV ctDNA had significantly worse progression-free survival, with a 2-year PFS of 51% versus 77% compared to patients without detectable HPV ctDNA. This association persisted when levels of ctDNA were measured at up to 3 months post-chemo-RT treatment. The authors proposed that ctDNA may help guide future studies to identify populations that are high risk for recurrence, in which to study additional treatment after chemoradiation. Stay tuned for more clinical applications of ctDNA in the treatment of cervical cancer. Investigation of ctDNA results collected during the CALA study also demonstrated prognostic value of ctDNA testing. Lots of good information in our podcast here today. Here are your key takeaways. Locally advanced cervical cancer describes FIGO 2018 stage 1B3 to 4A disease. Patients with locally advanced cervical cancer have a worse prognosis than those with early stage disease, with a 5-year survival dependent on the initial stage of disease.
Chemo-RT is the standard of care for locally advanced cervical cancer. This typically includes primary EBRT with concurrent cisplatin, followed by cervical and vaginal brachytherapy. Surgery is not typically performed in these cases as it has not been shown to have a survival advantage when compared to chemo-RT alone.
Cisplatin is the agent of choice for use in chemo-RT, but carboplatin can be substituted if patients have contraindications to cisplatin, such as chronic renal failure or severe baseline neuropathy. Typical dosing is weekly. However, ongoing trials are evaluating whether tri-weekly dosing is preferable due to feasibility and efficacy.
Pembrolizumab is FDA approved in combination with chemo-RT for patients with FIGO 2014 stage 3 to 4 cervical cancer based on the results of the KEYNOTE A18 study. which showed an overall survival benefit compared to chemo-RT alone. The CALA trial investigated durvalumab in combination with chemo-RT and did not demonstrate a significant improvement. Further research needs to be done to understand the nuances of treatment with different immunotherapy options.
The use of neoadjuvant chemotherapy followed by surgery versus primary chemoradiation alone has been evaluated in stage 1B2 to 2B locally advanced cervical cancer. These trials have not shown a benefit to this regimen and in some studies has been associated with reduced treatment completion and/or worse progression-free survival. Induction chemotherapy prior to standard chemoradiation was evaluated in Interlace. This trial also demonstrated an overall survival benefit compared to standard chemoradiation and is listed as an other recommended option in the NCCN guidelines.
Adjuvant chemotherapy after primary chemo-RT has not shown consistent benefit when compared to chemo-RT alone. Most recently, the Outback trial did not show a benefit in PFS or OS with the addition of adjuvant chemotherapy, and it did have increased toxicity. This has been another episode of Ready, Set, GYO, your source for all things gyno.
If you'd like to check out today's show notes, take some practice questions, or explore resources we use to create the podcast, head to readysetgyo.com, the companion website for our podcast. We encourage you to reach out if you have ideas for new episodes, questions or comments about existing episodes, or thoughts of how we can make this podcast even better suited for you. We're excited to continue to learn with you.
To stay up to date on all things Ready, Set, GYO, check out our Instagram and Twitter at ReadySetGYO.
To support us and our production of future episodes, check out our Patreon at ReadySetGYO.
This episode was recorded by Sydney Oesch and Maya Gross. Our sound editors are Brogan Brown and Kylie Knight. Our media and website manager is Sky Jacobson.
We'd like to thank Dr. Shannon Rush, faculty at UPMC McGee Women's Hospital, who reviewed the content of this episode for accuracy and completeness.
Sydney and Maya signing off.